Intimate partner violence is a preventable epidemic, and healthcare providers are uniquely positioned to impact that epidemic. When I look at some of the diseases in my own specialty, OBGYN, that we screen for regularly, gestational diabetes and hypertension, we screen on every prenatal visit and every postnatal visit. Those diseases occur in about 10% of pregnancies. Intimate partner violence affects somewhere between 20 to 40% of pregnancies, depending on our population. So we need to be screening in healthcare. Screening is a tremendous opportunity for education. Screening should be simple and direct. I always lead into screening by explaining why we're screening for intimate partner violence, that it is so incredibly common, affects 1 in 4 women, 1 in 7 to 10 men. Everybody knows somebody who's living with intimate partner violence, whether we know that or not. So I explain why we're screening, and then I ask some very specific questions. It's an opportunity for education because it's an opportunity to educate people that intimate partner violence is not just physical abuse. It's not just hitting, choking, slapping. It also involves control issues and sexual violence. So the questions I ask are, has your partner ever physically harmed you? Does your partner control your finances, your free time, your connection with family and friends? Has your partner screamed at you, yelled at you, or intimidated you? And has your partner ever forced you to have intercourse when you didn't want to? I have so many examples, but one that stands out to me is a patient who was presented at our grand rounds who had a unusual complication after a hysterectomy and came in with a very significant hemorrhage. When the hemorrhage was controlled, she did not want to go home. And many of us who had been in practice for a long time had never seen this particular type of complication. When the case was presented at grand rounds, I said, could this be a situation of domestic violence? And sure enough, when we talked to the patient and said, was there forced intercourse after the hysterectomy? She said, yes, there always is. And that was a huge intervention, a chance to save her life. So the other thing I would say is that in screening and educating universally, many patients have said to me, I myself am not in a relationship like this, but I have a neighbor, a friend, a niece, a granddaughter, a daughter, and there is so much shame and silence that surrounds this issue. People, even in your own family, sometimes don't know how to address it with each other. So to give people the tools to be able to say to somebody, here's a resource for you, here's what you can do, here's somebody to talk to about this. It's really incredibly common. I think one statistic that always blows my mind is that there are 250,000 new cases of breast cancer every year in this country. There are over 5 million incidents of IPV reported yearly in this country. And so to think that this is not a major health issue is really, just we're ignoring the facts. As I said before, 1 in 4 women suffer intimate partner violence and 1 in 7 to 10 men, so extremely common. It's just something that is there and is part of all of our lives, whether we know it or not. I think there are 2 main barriers to screening for providers. The first is time. People are overworked and overwhelmed, and there are so many requirements of what needs to be done on a routine exam. Once you have the script down for screening, it takes no longer than asking somebody if they wear a seatbelt or if they exercise regularly or how much alcohol they drink in a usual week. And none of us think that that's too much to ask a patient. I also tell people that in my specialty, if somebody were to come in with an unexpected miscarriage, I would never resent the time needed to stop, comfort that patient, link them with resources, and develop a treatment plan. And that's similar to what you'd be doing with somebody who has a positive screen for IPV. This is the same as in a primary care office. If somebody walks in off the street and has an acute respiratory issue or chest pain, you would stop and do what you need to do to care for that patient. This is why we're there, to take care of the vulnerable person. The second barrier to screening is the discomfort that providers have with not knowing what the next step is. We need to practice that. We need to practice what we're going to say if a screen is positive. We need to learn the script and be comfortable with the script. And we need to know the process as to how to link people with resources if they have a positive screen. These are all things we learn in our training. So we're very lucky in the state of Connecticut because we have excellent resources. And what I typically do, especially when I initially started universal screening, would offer to call CT Safe Connect with the patient privately in my office from our phone here, and let the patient speak to a domestic violence advocate while she was here. What we have moved to is having a trained domestic violence advocate in each office. So now it's an even warmer handoff for patients in that we say, let me call Michelle to come down and speak to you, who will then link you with resources. And I think that's been a wonderful, wonderful benefit for our patients and for us as providers from that time element that we spoke about. And, you know, my dream would be that every person knows exactly what to do when someone in their life shares this with them. One real tragedy that I heard about was one of our domestic violence victims in Connecticut the week before she was killed by her ex-partner had shared with two friends that she was afraid of her husband. And I think to myself, if those friends had known what to do or had said to her, let's go in and talk to your doctor about this, we can all make a difference. We can stop this epidemic.